My name is Alicia Martin, and today I'm going to be talking about the research that we at Brock University have been conducting in conjunction with the medical physics team at the Walker Family Cancer Center. We would like to start by acknowledging our partners in this project for providing funding or sharing their resources. Niagara Health's Walker Family Cancer Center delivers radiation therapy as well as many other forms of cancer treatments. Radiation therapy uses targeted high-energy photon radiation which damages cancer cells while sparing as much healthy tissue as possible. Patient-specific treatments are created and delivered by a team of cancer specialists, medical physicists, and support staff. In order to deliver these precision radiation treatments, medical linear accelerators undergo constant quality assurance testing to ensure that patients receive within 5% of the prescribed dose. In order to predict how much dose will be deposited, we first need to know the radiation field that reaches the patient. To do this, we use a detector called an ion chamber and a water phantom. The ion chamber gets mounted to the motorized holder and it's moved through the tank remotely. Water provides a good approximation for the human body as we are about 60% water. We then can use the theoretical physics models within the treatment planning system to convert the dose deposited in water to where it will be deposited in patient tissue. One of the most specific tests for linear accelerator quality assurance are called dose profiles, in which the ion chamber is moved through the water tank to determine the energy deposited. The goal is to produce a uniform radiation field at the patient level. By moving the ion chamber horizontally through the tank, along the x-axis and along the y-axis, we get profiles called inline and crossline profiles. If we move the detector vertically through the tank along the z direction, we get another profile known as the percent depth dose. Moving the ion chamber along these directions produces the inline and crossline profiles seen on the right, where in the field of the radiation we do see an almost uniform distribution of radiation, but within the percent depth dose we do see a very large change in dose as we get deeper in the tank. Linear accelerators involve high energy physics, and in this field it's very common to use computational techniques such as Monte Carlo to determine expected particle interactions. In medical physics, the theoretical physics models are all contained in the treatment planning system. Experiments can be done, however, with high patient volumes, it's almost impossible to test scenarios when the accelerator is not within clinical tolerances. For this reason, Monte Carlo is the simulation of choice. We used GATE and GEONT4. The Walker Family Cancer Center offers 3 different photon treatment energies in radiation therapy at 6, 10, and 18 MV. Our research aimed to study the difference to the patient dose when the average energy of the beam was altered. Moving the detector vertically down the tank produces the percent depth dose profile you see on the right. Instead of comparing the percent depth doses for all of our altered energy simulations, instead we take 2 reference points along the profile, one at 10 centimeter depth and one at 20 centimeters depth, and we divide them. The division is known as PDD 2010, and it's a measure of how penetrating the photon radiation is through the water. The tissue phantom ratio, or TPR, is another measure of this. It's conducted in 2 experiments, in which the first experiment, the detector is placed at a reference point and 10 centimeters of water is added on top. In the second scenario, the detector stays at the exact same reference point, but this time 20 centimeters of water is placed on top. The division of these 2 doses is known as TPR 2010, and it's given a clinical quality assurance value of 1%. Now, there's technically no reason that the TPR and the PDD 2010 should be the same value. However, they should be related as they both represent the penetration ability of the photons. This relationship was first determined by Followell et al. After taking data from multiple linear accelerators all across the United Kingdom. As you can see, all of our data follows the expected curve, meaning that we do get the correct response for our deviated energy simulations. We then went on to conduct an intensity modulated radiation therapy treatment. Our Monte Carlo data is the color plot in the background, and as you can see, it completely matches the contour experimental plot. Knowing that our data was correct, we then deviated the beam by half of a mega electron volt, which is the current clinical maximum tolerance, and redid the simulation. The image on the right is the dose difference between the 2. As you can see in the deviated beam simulation, the patient got about 10% more dose, which is well outside of the clinical accepted tolerance. For these reasons, we recommend that the TPR tolerance be brought from 1% down to 0.5% so that they are in line with the rest of the quality assurance guidelines, making sure that no patient receives no more than a 5% difference from the prescribed dose. Thank you very much for joining. I hope you all enjoy your day.
COACHED is a randomized, parallel, multi-center design trial that will look at whether a focused, multidisciplinary expert medication management intervention is feasible and might be effective in preventing anticoagulation-related adverse events. This trial was designed through the Division of Clinical Pharmacology and Toxicology at McMaster University and will encompass patients from several regional healthcare networks, including patients at the St. Catharines site of the Niagara Health Network. Anticoagulants are a ubiquitous medication class that provide well-documented benefits in medicine with important positive clinical outcomes in such conditions as chronic atrial fibrillation, mechanical heart valves, and venous thromboembolism. However, mismanagement of anticoagulants is one of the leading causes of hospital-acquired morbidity and mortality. Better management of these medications is consistent with the Niagara Health's 10-year strategic plan with a stated goal of reduction in patient harm, and the trial is a good example of an intervention using innovative integrated networks to help manage patients. The highest risk time period for anticoagulants in patient care seems to be shortly after hospital discharge. And with the recent evolution of virtual care as a practical reality, research looking into utilization of this approach for coordinating care and follow-up plans, as well as the transition of care, is both timely and of great potential importance. This study was approved by all of the ethics boards and data sharing stewards for the various regions involved in the trial. Moving to Figure 1, we demonstrate the overall flow of patients from the time they are admitted to the medical ward to their selection based on eligibility criteria and the obtaining of consent. Once patients are identified as appropriate for study, they're randomized either to the intervention group or the control group, and their care facilitated through to hospital discharge. The intervention protocol and comparator protocols are followed from the time of randomization through to the outcome assessment, which is the end of the study at 3 months. In terms of methodology, the patient population are adult patients on medical wards with a discharge prescription that includes an oral anticoagulant. The intervention itself is led by a clinical pharmacologist and an interdisciplinary team and includes a detailed discharge medication reconciliation, a management plan focused specifically on all anticoagulants. There's also a circle of care handover and coordination with the patient, the hospital team, and any community providers, including general practitioners. There's also follow-up arranged virtually at regular intervals post-discharge. The control group will receive usual care as standard in today's medical environment, along with encouragement to use the Thrombosis Canada website as a guide for home management. In terms of outcomes, we are looking at primary outcomes such as feasibility, with recruitment rate, trial resource utilization, and participation retention rates all factors to be analyzed. We will also look at clinical outcomes, including primary adverse anticoagulant safety event composite, coordination and continuity of care metrics, medication-related problems, quality of life, and health resource utilization. All outcomes will be followed for a total of 3 months. Currently, results are accruing as recruitment has been somewhat slow given the COVID-19 pandemic challenges. We are hopeful that this pilot study will provide us with enough intervention effect to warrant a full-size trial to better study outcomes. There is some early data suggesting that newer DOACs are less problematic than the more established Coumadin and their derivatives, and this particular trial should also shed more light on the effect of the newer anticoagulants on overall complication rates post-discharge in comparison to VKAs.
Reducing length of stay in colorectal surgery. Bed availability has been an ongoing concern and problematic for many hospitals. In 2021, despite the unprecedented impacts of COVID-19, Niagara Health's perioperative program committed to implementing a length of stay reduction initiative for colorectal surgical patients. The goal to alleviate bed utilization pressures through length of stay reduction strategies while also improving patient outcomes. Pathway was developed using a framework obtained from Enhanced Recovery Canada using evidence-based practices. This program has been developed in collaboration with Ontario Health, supported with NISQUIP data collected at Niagara Health. In order to implement the interventions, a gap analysis was conducted, identifying and supporting a plan for implementation. The gaps are as outlined on this slide. For implementation, the team created and researched current evidence-based practice care pathways for creation of educational materials, packages for patients and staff, as well as forming an oversight committee and educational supports for healthcare providers. Interventions outlined here. For quality improvement tools, the team used the PDSA cycle for facilitation guidance. For implementation, we followed the hierarchy of interventions using the SPAR framework. According to supporting data, surgeons are now showing increased effective utilization of the colorectal order set, with the order set being identifiable as one of the main contributing factors and decreasing length of stay. With surgeons utilizing the order set in accordance with the ERAS protocols, it's expected to continue producing ongoing positive results in patient recovery while keeping the pathway on track for patients to remain on target for their recommended discharge date. The ERAS pathway forms are a guide for healthcare providers supporting the surgeon's order set for colorectal surgeries. The ERAS pathway has been identified at the Welland site and the Niagara Falls site as needing some further education to remind staff to complete the ERAS pathway forms consistently, while inpatient nursing at all sites needs reminders to complete forms consistently as well. The following two slides outline the ERAS team goals for each ERAS indicator set at 50%, with the exception of VTE indicators at 80% and antimatic at 60%. The St. Catharines site has reached all of its goals with respect to the ERAS indicators, while the Niagara Falls site and Welland site have opportunities for improvement. All sites are showing success with the ERAS pathway, and there are a few areas of opportunity outstanding. Notably, the ability for the early intake of post-op solids and post-op liquids, as well as advising patients of the ability for clear fluid intake up to 2 hours before surgery, amongst others. The initial target goal was to realize a reduction of 2.9 days in length of stay, moving from 8.9 days to 6.0 days, 33% reduction within the first year of the ERAS pathway implementation. Within the first 4 months of implementation, length of stay has exceeded these initial targets, decreasing from 8.9 days to 4.1 days, achieving a 54% reduction in length of stay. Readmission rates support a negligible increase from the initial baseline before the implementation of the pathway, as well as with complication rates, showing minimal impact as well. Niagara Health has surpassed the set goals within the first 4 months of the implementation, with a 54% reduction in length of stay. Readmission rates, as identified earlier, show no material increase from the baseline rates, as well as no significant impacts to complication rates. Further studies will include healthcare provider and patient satisfaction surveys, measuring satisfaction with the changes, as well as patient recovery, as well as a study to understand the impacts for each step of the pathway in comparison to prior care practices. We'd like to thank the entire ERAS team and all healthcare providers involved for their ongoing support and contribution to the success of this initiative.
Hello, everyone. My name is Jade Chow, and I am one of 3 medical students working alongside Dr. Howe and Dr. Blewett on our randomized controlled trial, negative pressure incisional wound therapy for high-risk ventral hernia repair. So just to do some introduction, ventral hernia repairs are one of the most common surgeries performed by general surgeons and are frequently plagued by surgical site complications owing to the many risk factors which are common for the development of the hernia in the first place. Despite advances made through development and adoption of new prosthetic material and surgical techniques, wound-related complication remains a primary determinant of post-operative morbidity. American data from the National Surgical Quality Improvement Program reveals high rates of early readmission after ventral hernia repairs, with deep and superficial surgical infections accounting for a large majority of these. These and other surgical site complications are costly to the healthcare system and adversely affect quality of life for patients who suffer them. First used with favorable results by clinicians in North Carolina, negative pressure wound therapy, which I will refer to as NPWT for the remainder of my presentation, has quickly become a popular adjunct therapy for wound therapy in a variety of clinical circumstances. The mechanism of action of NPWT lies in a combination of direct and indirect effects, including reduction of wound edema, promotion of microvessel maturation, a reduction in bacterial burden, improved tissue apposition, and removal of exudate. Thus, NPWT has become popular in prophylaxis of wound complications in high-risk operations. However, formal evaluation of NPWT in closed incisions for abdominal hernia repair has largely been limited to observational studies in the form of retrospective cohort studies and case series. Randomized trials have examined the application of the technology in other surgical wounds, including cesarean sections and abdominoplasty, with good safety outcomes and mixed findings with regards to improved healing. Additionally, a recent Cochrane review of the topic found a high risk of bias in the existent literature, largely due to industry involvement. By performing a randomized controlled trial without industry involvement assessing the ability of the NPWT to reduce the incidence of surgical site complications in high-risk ventral hernia repairs, we hope to provide a higher level of evidence to support the therapy's clinical use and associated cost. It will also hopefully help elucidate which patients, if any, will benefit the most. Adoption of this technology in appropriate circumstances, if indeed superior to the current standard of care, could lead to significant decrease in associated morbidity, future healthcare costs, and improved quality of life. So in terms of our objectives, our primary objective is to evaluate, in comparison with standard sterile dressings, the impact of negative pressure incisional wound therapy in surgical repair of high-risk ventral hernias on the incidence of the composite of the following postoperative surgical site complications. These include surgical site infection, seroma, the presence of a non-healing wound at greater than 2 weeks post-operation, hernia reoccurrence, or fistula formation. In addition, we also hope to evaluate the impact of negative pressure incisional wound therapy on the perceived quality of life in patients undergoing surgical repair of high-risk ventral hernias and its cost effectiveness in comparison with standard sterile dressings. Now, you might ask, how exactly do we plan on achieving these objectives? Well, our study is a multi-center, open-label, randomized active control trial evaluating superiority of negative pressure incisional wound therapy in 2 parallel intervention groups. 110 patients with at least 2 comorbidities and a hernia greater than 3 centimeters in its largest diameter will be assigned to receive either a Prevena negative pressure dressing for 7 days postoperatively or a standard sterile dressing for 2 days postoperatively. After removal of the dressing, a follow-up ultrasound of the hernia repair site will be obtained at 4 to 6 weeks postoperatively, and the report of which will be used to identify occult complications. Furthermore, a quality of life survey will be administered 3 months after the patient's operation over the phone. Currently, the study is open with 43 patients enrolled at the time of this presentation, and as a result, we are not yet at the data analysis stage. However, for our primary outcome, we plan to calculate relative and absolute risk reduction of our composite primary outcome. In addition, we will compare Hercules scores to examine quality of life and use the per-use cost of the Prevena system, length of stay, and assumed cost per surgical complication to calculate an average patient difference in the cost of care between treatment arms. On behalf of our research team, thank you for listening to our presentation today. I look forward to answering any questions you may have about our research.
Hi, my name is Kian Rago, and I'm a fourth-year undergraduate student at Brock University in the Medical Sciences program.
And hi, my name is Ya Asari, and I'm a fourth-year undergraduate student at Brock University pursuing a degree in public health. We are both student researchers for the Interprofessional Education for Quality Improvement Program, iEquip, directed by Dr. Madeline Law at Brock University. Our project is focused on best practices for integrating virtual care beyond the pandemic, in which we partnered with the Niagara Falls Community Health Center, which is a community-governed multi-service healthcare center. The COVID-19 pandemic has resulted in the increasing use of virtual care, such as telemedicine. According to the Canadian Medical Association, virtual care describes the use of communication or information technologies for healthcare providers to interact with patients remotely to maximize the quality and effectiveness of care. Virtual services have shown an explosive transformation in the healthcare industry, with benefits extended to every member within the healthcare spectrum. This includes greater flexibility, access, and reduced costs for patients and providers. However, for some patients, virtual care presents a challenge for several different reasons. Thus, it is important to know that not every patient may be a good candidate for virtual care based on barriers such as access, language, cultural differences, or lack of digital literacy skills, to name a few. With virtual care likely becoming a permanent option for healthcare delivery in the future, it is important to be able to identify and understand the barriers that patients face from a variety of backgrounds. Our goal for this research project was to assess the virtual primary care program from a patient-centered lens. Supported by health equity and digital literacy considerations obtained from our literature review, we developed a toolkit to aid providers in determining patient eligibility for virtual care in a mixed care delivery model post-pandemic. Firstly, our research consisted of conducting a literature review to determine best practices and standards relating to virtual care. Heading into our research, we focused on health equity. We soon realized that digital literacy is a social determinant of health. From this review, 4 key arching themes that contextualize our findings are access, common barriers, patient preference, and continuity of care, with the respective sub-themes as shown. We then evaluated and thematically coded the provider and patient surveys based on the themes from our literature review and integrated all the recommendations into a process map.
With respect to the theme of access, patient responses suggested that virtual appointments improved access for 68% of the 234 respondents. Of the 24 provider survey responses that we received, many indicated that virtual appointments decreased the overall number of no-show appointments by decreasing transportation barriers. With respect to patient preference, most patients responded that they would like to see some form of virtual visits continued as part of their care. Of those participants, about 66% indicated that they would like to have some virtual visits, such as where a physical examination perhaps is not necessary. About 30% indicated that they would like virtual appointments in addition to their regular in-person appointments, so that they can be seen more often. And about 9% indicated that they would only like virtual visits. The remaining 34% of respondents indicated that they would still prefer all of their visits to be in person. The patient and provider responses, which was 75% of providers, support the continuation of a blended care model. With respect to common barriers, some providers and patients indicated that a lack of technology and digital literacy skills remained a barrier to virtual care in some situations. However, providers and patients also mentioned that wait times, transportation, language, time of day, and building accessibility can be other barriers to both in-person and virtual care. By offering initial in-person visits where possible, providers can properly conduct a physical assessment as well as establish relationships with patients to foster continuity of care. It also enables providers to properly assess patient circumstances and preferences. In combining our survey results with the recommendations from the literature, we created a sample screening tool to assess common barriers and digital literacy skills to aid providers in determining a patient's eligibility for virtual care. We also created knowledge translation videos to support eligible patients' transition to virtual care, which include information on the benefits of virtual care and tips for preparing for virtual appointments. It's important to stress that there cannot be a one-size-fits-all model for standardizing care assignment. Rather, patients and providers should work together to create a care plan moving forward which best addresses patient needs and preferences. The next steps for our project are to finalize our tool and implement it into practice to evaluate its effectiveness in terms of patient and provider satisfaction, as well as perhaps its contribution to improving efficiency. Thank you.
At the height of the pandemic, we wanted to evaluate how our patients and staff at the Walker Family Cancer Center felt about virtual phone visits versus in-person visits. To do this, 2 different surveys were developed and used to gather experiences from both patients and healthcare providers. The patient survey included both qualitative and quantitative questions and was administered via a phone call with the patient experience coordinator. The healthcare provider survey was sent electronically to physicians and nurses to assess their experiences with virtual care. In total, we had 121 patients take part. Patients were randomly selected based on having a recent appointment with their physician. All physicians were accounted for in patient selection. 10 physicians and nurses took part on their survey. Overall, the patient survey results were very positive. 82% felt very satisfied or satisfied with their physician virtual visit. 90% were very satisfied or satisfied with the information they received. 90% were very satisfied or satisfied with their symptom needs being met. Positive feedback included the following. It's way less stressful to do it over the phone, not just in COVID times. I would rather wait by the phone than in the office, and my husband gets to join in. The phone visit allows you to speak more freely because you're comfortable in your own atmosphere versus the office. I can be at home in my PJs all day, have a glass of wine, and get to talk to the doctor. You can't do that if you come and visit. I think if you're stable, then a phone call is fine. With COVID and everything, the safety of being at home in our own environment is ideal. However, some of the patients felt the opposite. I've never really met him, meaning their oncologist, which is really hard. Face-to-face is just easier for me because you can read a person's mannerisms and you can get into a different type of conversation. There's no connect. He's very kind and I have no problems with it, but it isn't the same as in person. You don't feel like you're getting assessed as thoroughly over the phone. I was looking forward to in-person for peace of mind with a physician exam. The physician and nurse survey results did not have the same overall satisfaction that the patients felt. 58% felt neutral about virtual visits versus in-person. 14% were dissatisfied, 14% felt satisfied, and 14% felt very satisfied. 44% felt dissatisfied about providing patients adequate information in a virtual visit. 14% felt neutral, 28% felt satisfied, and 14% felt very satisfied. However, using a no-reply email to provide patient information was a new method of information transfer implemented, used frequently, and is still used freely today. It turned out to be a really good decision. Overall, patients reported a positive experience with virtual visits. Other benefits included reduced travel costs and time spent getting to and waiting for appointments. Many patients expressed they would continue virtual visits, especially during the follow-up phase of their care. Physicians and nurses had mixed feelings. Overall, they felt neutral about virtual visits. Despite the convenience, they still felt they could not always provide adequate teaching and transfer of information, and that patients underreport symptoms. In more complex cases, there is a large potential for gaps or delay. The feedback from our surveys offers an opportunity for virtual visits in the future of care. Since then, we are still incorporating some virtual visits in our clinic and have since introduced some classes to the roster, including our new patient orientation, which has been well received on a virtual platform.
Hello everyone, my name is Neva and I will be presenting on a quality assurance review of interfraction target positioning variation in lung stereotactic body radiation treatment at the Walker Family Cancer Center. Before I begin, I would like to acknowledge that the land on which we gather is the traditional territory of the Haudenosaunee and Anishinaabeg peoples, many of whom continue to live and work here today. This territory is covered by the Upper Canada Treaties and is within the land protected by the Dish with One Spoon Wampum Agreement. Today, this gathering place is home to many First Nations, Métis, and Inuit peoples, and acknowledging reminds us that our great standard of living is directly related to the resources and friendship of Indigenous peoples. SBRT lung treatments are used to treat small and or early stage cancers. This is a treatment option for patients who are not surgical candidates due to age, comorbidities, and or performance status. Patients are prescribed a higher dose per fraction in fewer fractions. For instance, conventional treatment is typically 60 gray in 30 fractions, whereas SBRT can be 48 gray in 4 fractions. Literature has stated that patients treated with this technique often have mild side effects in comparison to patients receiving conventional treatment. The Walker Family Cancer Center first treated its first patient in March of 2021. The purpose of the study was to assess the interfractional target position variation in patients receiving lung SBRT. CBCT treatment couch displacement, which is also referred to as shifts, were assessed for 42 patients who received this type of treatment between March and November of 2021. All of these patients received the same immobilization and were all treated on one linear accelerator. In terms of workflow, the patients were positioned by the radiation therapist, after which the therapist would complete a pre-treatment full revolution CBCT scan, followed by a half verification scan if there were any shifts greater than 0.5 centimeters. The therapist would complete a mid-treatment CBCT scan on all patients before delivering the last beam to verify the target location. These shifts were recorded and averages and standard deviations were calculated. We also reviewed patient characteristics such as gender, age, tumor location, and comorbidities. In this analysis, we found that upper left tumors had the largest average shifts in the longitudinal direction, while lower left tumors had the greatest lateral and vertical shifts. 57% of males had the largest longitudinal shifts. In addition, 67% who had the largest longitudinal shifts were over the age of 70. We also found that 70% of patients with the greatest longitudinal shifts had comorbidities such as COPD, arthritis, and or a cardiac condition. Finally, patients with tumors larger than 2 centimeters had larger longitudinal shifts. This graph displays the average longitudinal shifts based on the first CBCT done, organized by laterality of tumor location. As you can see, the largest displacement was found in upper left tumor lesions. This graph shows the average lateral shifts based on the first CBCT performed, where the largest displacement was found in patients with lower left tumors. This graph shows the average vertical shifts, where the lower left tumors had the greatest displacement, while the upper left tumors had the least. Based on this data, we found that the majority of the patients had no shifts after the initial CBCT, which shows that this type of treatment and the immobilization for the patients are safe and accurate. Implementing this type of treatment at the WFCC has benefited the Niagara region as it enables patients to receive a highly sophisticated treatment within their community. Prior to this, patients would often have to travel to other city centers. Further investigations should be done to assess if modifying the current immobilization would impact the magnitude of shifts seen in the longitudinal direction.